I am going to try and go through 43 slides in 15 minutes, and so I'll go through parts of them quickly. But what I'm going to try and do in the next 15 minutes is to go through with achalasia, what the cause is, how it presents, how is it diagnosed, and then what options do we have to treat. So if we look at the word, it's Greek meaning essentially no relaxation, and it basically refers to a disease that's from unknown causes where you lose inhibitory neurons within the bottom of the esophagus. And so what happens is you get this tonic contraction within the lower esophageal sphincter, and then you lose peristalsis above. It's thought to occur at a rate of 1 in 100,000 per year. It can occur at any age, but it's more common past the age of 65, and it tends to affect both men and women the same. First described in 17th century by Sir Willis, who's also responsible for a bunch of other different discoveries. But it's an interesting case that he had one patient who had achalasia, that he took a whalebone and then placed a sponge at the end, then had that patient treat himself after every meal, and that lasted for about 15 years until he died of something else. Now we do have better therapy since that point, but it's still a somewhat similar concept, and so we've been doing pneumatic dilations at this point for about 124 years. We've been doing Heller myotomies for at this point 109, and the newest one is POEM, which was first conceptualized back in 2007. So I'll talk about those more. These patients present with problems swallowing. Classically, it's problems with both solids and liquids, but there are people who in the early stage will first present with just solid issues. So while classic solid and liquid, if they have just solid, it does not exclude it if it's early. Typically, these patients will take a while to get diagnosed, and so in most of the older series, from symptom onset until a diagnosis is made is about 5 years. One thing that's somewhat that is a little paradoxical is heartburn. About 40% will say they have that, and the thought there is that it's not that they have more acid coming up; it's that what comes up doesn't get cleared. So they get the same symptom, but the cause is different. But our brief look in terms of causes, and this part I'll jump through pretty quickly, is how we get this esophagus from being healthy and such to this one you see on your right hand side where it's dilated and contracted at the bottom. So once again, loss of basically loss of neurons in the inhibitory pathway. It used to be thought that these neurons were lost and kind of just disappear over time. And back in the 90s, there was were a few groups that found some inflammatory change in the area, and that led to a couple different theories. Bottom line is that there were two main theories which were proposed. The first one is an autoimmune reaction. Second one, possibly infectious. And there's been a number of groups that have looked at both of those. The bottom line is that there's supportive evidence for both of those as well as contradictory. To make it a bit more interesting as well, parrots get achalasia, and it's been found that this is actually the second most common cause of parrot death. And in parrots, they've found a type of virus which will induce this, but that's never been found in people. And so the current theory that unifies this is that people get some sort of reaction towards an infection that's probably viral, and then they induce they induce a infectious response towards it, which triggers an immune cascade, and then that at that point affects the neurons in the area. So once again, incidence of 1 in 100,000. But what's interesting is there's been 2 papers within the last 5 years that have shown that for reasons that aren't clear, it's probably about 3 times more common within the past decade. And so you take the increase in incidence, which also seems to link with as well an increase in as well in different immune sort of linked disorders. And then you take the fact that we have good therapies and people live longer. And whereas the previous prevalence was quoted as being 8 to 10 per 100,000, it's probably at least 5 times that now based on that. So for something that's relatively rare, we see a new case of this at least once a week in clinic. Typically, to make the diagnosis, the main symptoms is typically dysphagia, and so not surprisingly, the next step is typically endoscopy or else a barium study. There's no data that doing one of these is necessarily better than the others, and there's no guidelines which will recommend doing one of them first. And so it really becomes a question more based on sort of local expertise and practice patterns. Now, both endoscopy and barium studies are relatively insensitive, particularly in the early years. And so, classically, with endoscopy, you'll see dilation, you'll see food retention, the subjective pop upon passing the sphincter, and then frothy secretions. But really, this is more in the later stages, and oftentimes with endoscopy in the first few months and years, it comes back looking pretty normal. With barium studies, very similarly. And so the classic image on boards always is this bird beak appearance, retained food, and such. But really, that's seen in about 1/3 of patients with achalasia. And so, once again, in the first few years, often what you see is more these tertiary contractions and spasm. So what do you do if both the endoscopy and the manometry or if both the endoscopy and the barium study are normal? And we have a few tests which are out there, and I'll go through the first two. The first one is manometry, which is considered to be the gold standard right now at looking at possible dysmotility in the esophagus. And the way this works is you take this catheter that has 36 solid state sensors, and it's about the same width as, say this cord, a little bit thinner. And you numb up the back of the nose, you pass the tube down, you ask them to swallow, you place it so that it straddles both the upper sphincter and the lower sphincter. And then this tube looks at pressure. And so here, essentially, you're seeing someone that has a swallowing that's normal. So at the top of the screen, you've got the upper esophageal sphincter here. Then that tends to open with swallowing. You get this bolus pressure that comes down. The lower sphincter opens, and you've got this nice stripping wave that comes through. And contrast that with someone with achalasia. And you can see that you don't have to be a motility expert to look at this picture and see that this is shockingly different. And once again, the lower sphincter is staying tight. You've got higher pressure in the esophagus. That nice stripping wave, which we saw here, is entirely gone, and you've got this isobaric pressurization. And it so it used to be that to get a manometry would make the diagnosis, but there wasn't a lot of prognostic info from that, and that changed about 14 years back. And there's now been type 1, type 2, and type 3, which are talked about. And so type 1 is where you have a tight lower sphincter, but you don't make any pressure in the esophageal body. And so this is a group that is thought to be often more of an end stage. Type 2 is where you have the same lower sphincter, but you can see you make this isobaric pressurization within the esophagus. And the thought is almost that it's like if you were to take a balloon that's filled and you add 10 cc's of extra air, that air doesn't make a stripping wave, it just increases the pressure throughout the whole esophagus. And so this is thought to be a stage which is possibly earlier, where you can still generate pressure from the outside muscles within the esophagus. And then type 3 is where you get the spasm. And so in this situation, the lower sphincter is contracted, but you get these spastic contractions above. And what's been shown now with this by so far at least 8 different groups is that your outcomes with going and treating this vary based on what subtype it is. And so subtype 2 really responds to just about everything. 1 seems to do much better with therapies that really disrupt the sphincter well. And type 3, which is spastic, you tend to get better results if you treat not just the sphincter, but the esophagus above as well. Now, the test that's newer that's gotten a lot of attention within the last five years is FLIP. And what this is specifically is this relies upon impedance rings, which are placed inside a balloon. And you can place this anywhere in the body, but what it does is it lets you look at diameter and pressure within the cavity. And so where this has been useful with this specifically is that it's possible to place it across the sphincter and measure diameter and look as well at sensibility. This was FDA approved in 2010, but it really came into its own about 5 years back with this technical review in clinical gastroenterology. And they've since adjusted it so that it's possible to look not just at static pressure or not just at a static diameter, but also to take this with time and make a plot that looks pretty similar to manometry. So this is one example where this was helpful in my own clinic. So I saw this patient who was sent to me with a long history of dysphagia, but he'd had a pretty good workup. He'd had 3 local endoscopies. He'd been stretched twice. It didn't make much difference. He had a barium study that showed spasm. He had 2 attempted manometries that showed spasm, but the sphincter looked okay. And so we ended up looking with FLIP in him. And what you're seeing here is on the left-hand side is this catheter placed across the LAS with 20 cc's of fluid in. And then the right-hand side, it's in the same area with 50. And what you should see is that this opening should go from 5 on this side to at least 15 or so here. And it stays at 5, it just moves up a little bit. And so it looks like what's happening is when he gets pressure in the area, he does get contractions with the outside muscles that then shortens the esophagus. And that was interpreted as looking okay from the manometry, but his sphincter is staying tight. And so based on this, we could look and say that he does have a defect with his sphincter and then send him towards POEM. So in the last couple minutes, how exactly to treat this? And we have 7 options. So bottom line for all of these is that there's 3 of them which are good, the rest are not. So the goals are to try and make symptoms better, improve emptying, improve quality of life, but also to prevent the esophagus from stretching out. And if we go through and look at these, just doing nothing doesn't work. These patients they do okay for about 5 to 10 years, and then things stretch out, they get aspiration, and then at that point, just opening the bottom is not effective. Doing medical therapy, there's a couple different things which are looked at. Bottom line is it doesn't change anything with the natural history, but it can be used as a bridge towards doing something definitive. Botox has gotten a lot of attention, works in about 70% of people, but it only lasts for about 9 months. And every time you do it, there's a little scarring associated with it. So where I find it helpful is if you're not sure of what the diagnosis is and there's data which somewhat is a bit uncertain, then doing this, if they get better, you're at that point confident that you're going down the right path. Or if they're very frail or old and you're not sure that they've got the strength necessarily to go ahead with something definitive. The 3 which I think are reasonable, dilation has been in use to this point since the 19th century. We can take a balloon and stretch it up to about 4 cms in size. And what you're attempting to do is to stretch the sphincter to tear it, but not completely tear it. So it works in about 70% of people, but the challenge is the rate of perforation is between 1 and 4%. So it's something that we used to do a lot. I think at this point we don't do it as much just because we do have very effective options which are safe. But if you have a patient who really doesn't want to be in the hospital, who wants who wants to go home that same day, then this is a valid option. Hellar myotomy has been in use at this point since 1913. It's been in use via a laparoscopy approach since 92. Success rates are about 90%. And where this is helpful is that you can combine it with a partial wrap. And so if you're really worried about GERD, this is the most effective option to treat that. But it does require going in and doing actually an operation, keeping them in the hospital, and it's a slower recovery because of that. And then the last one that's out is called POEM, and the concept here is that you dissect the wall of the esophagus. You then cut the sphincter from the inside. And so what's nice about this is that there's no scars from the outside. Recovery is really fast, works very well. Success rates are 90% or higher. The downside of it is reflux, in that this is the most effective way of cutting the sphincter. You are cutting it from the inside, which we think is where most issues stem from in this particular disorder. But because you are cutting the sphincter most effectively, you are cutting the sphincter most effectively. So GERD in most series is about 40%. There's also the fact that the first case in people was only done in 2010. So we don't have a lot of long-term follow-up, but what we have so far looks pretty good. So last slide here, just the key points to take away. This does appear to be increasing in frequency. If you think this is a possibility and you don't have a clear answer from the endoscopy and the barium study, a manometry is a good next step. The subtype can help predict which therapy they are most likely to get benefit from. FLIP is the new test that's out there. It has the benefit of being done during endoscopy when patients are sleeping. So for those people that can't tolerate a manometry or don't want it, FLIP is becoming a viable option to test. Botox is, really an option in people who are very old, very frail, or you're not completely sure of what the diagnosis is. And then if looking at long-term options, doing large caliber dilation versus Heller versus POEM are all valid options, and it really becomes a choice based on local practice patterns and expertise in that scenario. Though I will say that POEM is becoming the standard of care in those centers that do a lot of it. So thanks, appreciate it.